Hello, everyone, and welcome to Unit 8. In this unit, we actually have 4 lectures, the first of which is focused on computerized physician order entry, also known as CPOE. This quote from Van de Velde provides a good starting point for our discussion of computerized physician order entry. So just take a second. What does this quote suggest to you? Says much of a patient's care plan is expressed through orders. Those of you that are nurses can probably really relate to this. The order in the healthcare setting is a foundational component of the way healthcare is delivered, and a majority of healthcare costs are determined by what the physician orders. So why is that? Let's explore this a little bit further. So take a second here and reflect back on something we discussed in our last unit, which was the SOAP process, or SOAP, which is the problem-oriented decision-making approach that forms the foundation of clinical practice. And I'm going to quickly advance the slide here to show these again, just as a reminder. So the physician uses objective and subjective information to form the basis of a professional opinion as to the diagnosis of a patient. The physician then prescribes a course of treatment or a care plan for the patient. And the process of collecting evidence to form a medical opinion is not done in isolation. The clinician draws upon the resources of others in their efforts to provide the most complete and accurate diagnosis and to ensure the best care is delivered. The clinician uses an order to access services on behalf of the patient and other areas within the healthcare delivery system. So the order is a legal document that characterizes the nature of the physician/patient relationship, and that the physician accepts a duty of care on behalf of that patient. Laws also govern who can actually request orders. In North America, physicians or MDs have the broadest authority to place orders. However, physician assistants, nurse practitioners, and other advanced practice registered nurses have a level of authority as well in certain circumstances. Other healthcare professionals, including dentists, psychiatrists, and so forth, also have order authority. These restrictions on who can place orders are intended to protect the public from misuse of tests, substances, and so forth. Clinicians can place a number of types of orders. These include clinical assessments, such as a request for a hearing test. These are typically performed by a specialist. Orders for lab tests include a broad array of laboratory tests and procedures to assist with screening, diagnosis, treatment, and monitoring, and these are typically performed by a pathologist. Orders for imaging studies include requests for X-rays, MRIs, CTs, or other scans of the human body, and these are typically performed by a radiologist. Orders also include requests for medications or controlled substances for treatment, and these requests are made through a pharmacist. Most orders contain common elements, including information regarding all parties to the transaction, including the patient, the requesting or attending physician, and the provider of the requested service. So this would be that radiologist or pharmacist, for example. Typically, the patient's condition is identified using a standard terminology such as ICD-10. The actual order itself usually captures the item request, the time of the order, start-stop dates, frequency, and urgency. Other factors may also be highlighted that may be complicating conditions, such as a pregnant patient or a patient with a pacemaker. As you might expect, paper orders present their share of challenges. So take a minute to see if you can decipher this actual paper physician order. So what is the course of action the physician has requested here? Most people have a really hard time deciphering this request. I know I do. This example is just meant to highlight the potential safety risks associated with paper ordering. Illegible handwriting, transcription errors, errors in documentation can all have potentially devastating impacts on patient care. So remember that IOM report? So it was back in 2000 when the Institute of Medicine issued a report on errors in healthcare originating from inpatient care. And the report estimated that 2.9 to 3.7% of patient hospital encounters included an adverse event. Of patients with an adverse event, 8.8 to 13.6 of those patients died. More than half of all adverse events were preventable. The most frequent errors in healthcare include failure to diagnose and medication order errors. So developed out of a recognition that automating the order taking and filling process should reduce errors and lower the number of adverse events. It does this by eliminating the need for handwritten orders, right? So it's the handwritten orders were a major and important source of errors, and so they developed CPOE. However, it's the ability to embed decision support capabilities into CPOE that really drives its value from both a cost and a quality perspective. So use of decision support allows for early detection of potential ordering errors. It also offers a range of diagnosis and treatment related information and tools aimed at improving care. Decision support can also include rules regarding allergies, drug-drug interactions, medication contraindications, and renal and weight-based dosing that can ensure the patient receives the correct prescription. Modern CPOEs have several features, most of which have been discussed here, but standardized ordering is facilitated through the CPOE and can be individualized as needed using order sets. Order sets are a combination of tests that are run together as part of a standard screening or diagnosis process. Patient-centered decision support provides the physician with information on medical history, current test results, and guidelines to support treatment decisions. Patient safety features include real-time patient identification and appropriate alerts to ensure that orders are patient appropriate. And regulatory compliance and security is critical as well to ensure that only those with appropriate authority can make order requests. So let's talk about the benefits of CPOE. So derived benefits from CPOE are generally well accepted with good support from evidence, right? So improvements in the overall healthcare delivery process, including a clearer record of a patient care plan, the elimination of lost orders, improved order handling, and less ambiguity in terms of interpreting physician order requests and their handwriting. It enhances communication within the health system, including better communication between various parties regarding appropriate patient care. Most effective communication leads to fast turnaround times in order placement. And so the ability to trace life cycle of orders and to monitor patient progress within the process of care is also a benefit. And then lastly, increased cost consciousness. So the benefit is seen on several fronts, including evidence of lower adverse event costs that lead to lower lengths of stay and improve outcomes. So while research suggests that much good can come from clinicians entering orders directly, other unintended consequences can arise. So first of all, inexperience can lead to delays in entering orders. In fact, this is one of the most frequent complaints regarding the use of CPOE technology, particularly among new users. Physician and nurse communication can decline if each group works independently. Automation can cause a false sense of security that errors are avoided. And it was a combination of these factors that led to an actual increase in mortality at the Children's Hospital Pittsburgh Pediatric ICU when a CPOE was introduced. So frequent alerts and interruptions also can impact workflow, leading to alert fatigue. So in summary, most physician care comes through orders. Manual order systems are error prone and a primary source of adverse events. Computerized physician order entry systems have been shown to be effective at improving safety and lowering costs associated with adverse events. And lastly, introducing CPOE into a complex medical environment is not without risk, right? Health informaticists involved in the deployment and management of such systems should be aware of potential pitfalls in the use of these tools. And a few references. All right, thank you. And on to number 2.